Good afternoon, everyone, and thank you for joining us on this SCI talk called A New Era for Dementia Research, Challenges and Opportunities in Developing New Treatments. This is the second of a trilogy of talks on dementia, so I invite you to make sure to go to the SCI website later and join us for the next session in November. Just a bit of housekeeping to start. There'll be a Q&A session at the end of this talk. So if you want to ask questions, just make sure you type them in the question box at any time, and I'll be asking them at the end. And just note that all attendees are listen-only mode. I am Dr. Paul Hernandez. I'm a postdoctoral research fellow in medicinal chemistry at the University of Oxford, and I work with Professor Angela Russell on the development of metabolic modulators in collaboration with Novo Nordisk. And today it's my great pleasure to introduce Susan Kohlhaas, who is an Executive Director of Research and Partnerships at Alzheimer's Research UK, the UK's leading dementia research charity. Here, she oversees the charity's research program, research strategy, and leads on scientific partnerships. Susan has over 15 years of experience working at medical research charities, having previously held senior roles at the National Cancer Research Institute and the Multiple Sclerosis Society. Before moving into the charity sector, Susan completed a PhD in cancer cell biology at the University of Leicester and postdoctoral experience in immunology at Brigham Institute in Cambridge. And today, Susan will be telling us about a new era of dementia research, the challenges and opportunities in developing new treatments. Thank you, Susan, and I'll hand over to you.
Thank you. Fantastic to be here. So I really appreciate the invitation. I'm just going to try sharing my slides. So this is always the test of the day. So hopefully everyone can see that in presenter mode. So again, really pleased to be here. And I actually had to change my slides about an hour ago because there are some new news stories and breakthroughs that you may have seen hitting the news this morning. So this is all very hot off the press. But I just wanted to start by outlining what I'll talk about today and really looking forward to hearing your questions as well. So I'll give you a little bit of background about Alzheimer's Research UK, why we exist and what we're here for, as well as our approach to how we fund research. I'll talk a little bit about dementia and then give you an overview of progress that we've made in dementia research, particularly focusing on the last 30 years or so, and then start to talk a little bit about opportunities in the field and where we see the priorities for the field ahead. So just to give you a little bit of background, we're the UK's leading dementia research charity, and we were founded around just over 30 years ago now, actually, with a vision to have a world free from the fear, harm, and heartbreak of dementia. And one of the things that we've noticed in our 30 years of existence is that there are real misconceptions about dementia and Alzheimer's disease. So many of the things that we hear from people on the street is, oh, dementia is just an inevitable part of getting older. There's nothing that can be done about it. And that is a real challenge to try and change that stigma and that misconception that exists. We know that Alzheimer's disease and dementia are not inevitable as we age. Many people live with the risk factors of Alzheimer's dementia and never go on to develop the symptoms. So one of the early pieces of work that we've done as a charity is to try and change that misconception. So you'll see Samuel L. Jackson here did a campaign for us called Share the Orange, which outlined that the brain shrinkage that happens over time is a result of physical changes in the brain. Therefore, dementia and Alzheimer's disease are diseases, and we can do something about that through research. Last year, we launched our campaign called Change the Ending, which was about how research has the power to change the outcomes for people living with dementia. And we're starting to see some real traction in that space. I'm really excited to talk to you a little bit about that today. And I guess in terms of how we see ourselves as a research funder, we try to be fairly focused, actually. So focusing on funding the best research in the space of developing new treatments, understanding and developing new diagnostic tools, and also working through how to promote brain health and prevent cases of dementia in the future as well. And we aren't a funder that aims to fund end-to-end across the research pathway. What we try to do, because we are the largest charitable funder of dementia research in the UK, but we know that we are working in a complex landscape. So we try to find where the gaps and blockages are across the research pathway and focus our efforts there. So I'll talk to you about a few of the initiatives that we have running at Alzheimer's Research UK and some of the outcomes that are coming out of those as well. This is just a little bit of information about dementia, so in case you aren't aware. So actually, one of the things most people don't know is that dementia is actually the UK's leading cause of death, and has been for some time. And if nothing changes over the next few years, 1 in 2 of us will either develop dementia ourselves, care for somebody living with dementia, or both. So it's a real crisis of our time. There are nearly a million people living with dementia in the UK right now. And it's costing the UK economy about £42 billion a year. And the majority of that cost is actually borne out by the families of people living with dementia. So this is a really important area to tackle, and really important to start to develop treatments to try and shift the dial in terms of how we treat, slow, stop, and reverse the effects of dementia. Many people ask us every day, what's the difference between Alzheimer's disease and dementia? And I know you've had a talk on what dementia is anyway, but I thought actually it's quite useful to have this slide up. So Alzheimer's disease is the most common form of dementia, but actually there are over 200 different types of dementia. It's dementia is a kind of complex set of symptoms that people get, of which Alzheimer's is the most common. And what we see in Alzheimer's disease and other dementias is that we get early symptoms that can include things like memory loss, confusion, disorientation, but they can vary across different types of dementia, and they can vary within different people. Alzheimer's disease, which is probably the one I'm going to focus on most today, is characterized by the buildup of a set of proteins called amyloid in the brain, followed by the buildup and seeding of another set of proteins called tau. The buildup of these proteins can happen up to 20 years before symptoms are detectable. So this is a real challenge for the field of when can you intervene early enough where you're able to make a difference, but not so early that you can't measure that difference over time. We do think that earlier treatment will probably lead to better outcomes, just because in neurology and neuroscience, there is a certain amount of resilience that is built into the brain, and a certain amount of redundancy that's built into that. By the time you're getting symptom onset, you've already lost a significant amount of brain volume. And so actually, if you can move treatment earlier, you can probably save some of that and improve longer term outcomes. And the time from diagnosis to death really varies quite a lot. And I think that's partly because there could be improvements made in how and when we diagnose people, but it can be on average between 3 to 11 years. But again, that's inconsistent and varies quite a lot. What we've seen in the field is a real acceleration in the discoveries that have been made. So this is just a very rough timeline of some of the earliest discoveries that have been made, and then some of the later stage work that's been done. So Alzheimer's was first described as a peculiar disease in 1906, and just over 100 years later, we've now got our first licensed treatments for the disease as of July and today. But in between that, there was a real challenge in terms of the number of failed trials that we've seen, the difficulties we've had of characterizing the disease, the difficulties we've had of following people up over time. And that's partly because of the stigma of people coming forward for diagnosis. And it's partly because we haven't had the tools that we've needed to assess the disease and map that to the clinical characterization of the disease. So it's really important that now we've got some good tools of which to use, and we've got our first treatments starting to come through. We're really set to make more progress. And then I just wanted to go through a little bit what's changed in the last 30 years, so since Alzheimer's Research UK was set up to where we are now. And so 30 years ago, there weren't really any treatment options for people living with dementia, including there were no specific symptomatic treatment options for people living with dementia. Now we have our first treatments that are actually affecting the underlying mechanisms of the disease. So they remove amyloid from the brain that's building up. And that's as of this year, we've got our first licensed treatments. There was no specific diagnosis for dementia. So I had a close relative that clearly had Alzheimer's disease in the mid-90s. And essentially the diagnosis was, well, wait until he's died, we'll do an autopsy and we'll see if it was Alzheimer's disease. Now we've got a much more accurate and more timely diagnosis, and that's becoming more increasingly more available as well. So people can have, not only can they have cognitive testing that's very accurate, but they can have PET scans and lumbar punctures to measure the protein that is building up in the brain. And there's much more work happening in this space. We expect to make some strides in this over the coming years. We had a really poor understanding of the biology of dementia. So again, we were starting to understand that amyloid was an important protein that's built up in the brain in the early 90s. But beyond that, there was a lot more to do. Now we're starting to see that dementia and Alzheimer's disease specifically is probably caused by a multitude of factors that probably need to be tackled altogether. So we're starting to have a much more nuanced understanding of the field. And understanding more beyond amyloid. And then again, there was a misunderstanding and stigma in society that really, I think, held research efforts back quite a bit. So people not necessarily wanting to talk about dementia openly, people not necessarily wanting to come forward for a diagnosis. Now, when we do our work and ask people these questions, majority of adults disagree. So they think that dementia is not an inevitable part of aging. And that's really important for us to start to try and get people involved in research and to get them through into the clinical system. And then just in terms of our understanding of risk factors, we really only understood that age and genetics were the risk factors that we'd identified. So as you get older, your chances of developing dementia increase. And we know that there's a really strong genetic element, particularly to some forms of dementia. But now we have 14, not beyond age and genetics, we have 14 modifiable risk factors that have been identified across the life course. And I'll talk a little bit about those as well. So a lot has changed in 30 years, although if you look on the tin or if you just look at the surface, it doesn't look like things have changed. A lot has started to change in terms of our fundamental understanding of dementia and what we can do about it. The other thing I wanted to say is that 30 years ago, the annual global research spend on dementia was £189 million. That was dwarfed by the spend on cancer or heart disease. Now it's 2.9 billion. Many people will argue it's still not enough. I think there is more that we could do if we had more investment in funding, but it's much greater than it was. And I think that's a reflection of where the field is as well. I just wanted to show this. This is a slide I inserted today. So we have 2 new treatments that have been approved for early stage Alzheimer's disease in Great Britain. So the first is called Leqembi, and it was approved in August. I think it was August, actually. And the second is called donanemab, and that was approved as of today. They are first generation treatments. So as many of you will be aware, first generation treatments are never perfect. They're modest in their effect at best, really. So they slow cognitive decline by about 30%, sometimes up to 40%, depending on the patient population you look in. They do also come with serious side effects, a serious side effect called ARIA, which can cause mini brain bleeds, often is asymptomatic, but can cause mini brain bleeds, which can be really problematic as well. But one of the things I always reflect on is that having the first generation of treatments is really important in terms of providing a pathway for people to get into the NHS, to get that diagnosis, and also to start to work out how we can treat these diseases within the context of the health system. So it's a real step forward. The challenge that we have with this is these treatments, again, as with many first generation treatments, have not been deemed cost effective by NICE. So not only the cost of the treatments, but the cost of the diagnosis, additional scans, and safety monitoring of these treatments mean that they won't be deemed cost effective. So as it currently stands, these drugs could be available privately to people in the UK, but not on the NHS. And I think we have major challenges across the UK of moving innovative first generation treatments into patient populations within the NHS. So again, we've written to the Health Secretary to outline those challenges. We've been talking about this moment for about 10 years now at Alzheimer's Research UK, and we're encouraging anybody who can to log into our website, write to their MP, and try and work through how we make some of these innovative medicines more available to people across the UK, so that people on the NHS can access them in a controlled way. But I just want to stop and reflect. So after years and years of having many trial failure after trial failure, and people in the scientific community really losing a little bit of hope, we now have our first two treatments approved as safe and effective in Great Britain. And I think this is a real milestone moment and should be the basis for further developments, making safer, more effective treatments, and starting to make treatments that tackle different aspects of the disease as well. And I should also say these treatments remove amyloid as it builds up. So they remove the protein that's building up in the brain, is one of the early hallmarks of Alzheimer's disease. But I think given that we've made some progress, I think that's fantastic. And that's a result of real efforts across the global scientific community. I think there's some really big challenges, and I think access to treatments is one of them. But I also think suitability of treatments and making sure that we're not just hyper-focusing on one scientific mechanism or one area, but starting to look at how we broaden out the treatment targets that we're looking at. I think also is coming in part and parcel with that is diagnosis. So at the moment, the NHS in England says that their target for diagnosing dementia is 66%. So they are trying to get 66% of people who have dementia diagnosed in England. Often that diagnosis comes really late. So it comes when the dementia is very severe, at a much more severe stage than when somebody might be eligible for treatments. And it can also come as a very generic diagnosis. So it will be a diagnosis of dementia, but not necessarily the specific type of dementia that people have. Only 2% of people across the UK have access to the PET scans or the lumbar punctures that give you a really specific diagnosis of what's going on in your brain. And that can be a real challenge when we're starting to talk about treatments as well. And we really need much more scalable, cheaper ways of diagnosing people, or tools that help us get people into that diagnostic pathway. I think the other thing is, one of the things that we're noticing is that you can actually reduce risk of dementia if you intervene early in life or midlife by trying to encourage healthy lifestyle pathways as well. But many people aren't aware of that. So we're trying to work with others to try and raise awareness of what you can do in your life to reduce your risk of dementia going forward. So there's a lot more to do. And what I'll do is I'll talk about treatments, diagnosis, and prevention, and then we can have some time for questions. So again, in the space of diagnosis, 30 years ago, this was mainly based on symptoms and some early cognitive tests. Confirmation was only possible post-mortem, and we'd only just started to identify the first risk genes that were associated with dementia. Going back 5 years ago, so this is about when I joined Alzheimer's Research UK, we had started to incorporate imaging techniques, so MRI, CT scanning, some advanced techniques like PET and fluid biomarkers were being developed. And we were starting to really test, or we had made a lot of progress in testing familial cases and starting to do genetic testing for people with rare forms of dementia. And then now we're starting to look at blood biomarkers. So 4 years ago, some landmark papers came out looking at p-tau217, which is a blood biomarker that seems to match PET scans and CSF with good correlations. And so we're starting to test those in the UK and work out how they fit within the diagnostic pathway. There are also other additional diagnostic approaches we're looking at, and I'll talk a little bit about those later. And I think with AI and machine learning tools, we're starting to work out how we can analyze data, particularly brain scans, and predict risk over time. So I wanted to highlight a couple of things. So this Blood Biomarker Challenge is a program we launched in partnership with the People's Postcode Lottery, who are funding the lion's share of this work alongside Alzheimer's Society, National Institute of Health Research, and Gates Ventures. It is trying to take the blood tests that are being developed and have been compared favorably against PET and CSF scanning, and trying to work out whether they work in the real world. So it's moving from early scientific discovery through to how does this work in terms of adopting it onto the NHS. So we've got two 5-year studies that we're funding. So the first is called Readout, and it will focus on a particular blood biomarker called p-tau217. And the second is called Adapt, and it's going to be looking at whether you can develop a panel of novel biomarkers to look at a range of types of dementia. And what's really important is in these studies, we are trying to look at real world populations. So we're not necessarily wanting to look at a research only population, but start to broaden our testing out to real world populations, because some of the challenges of adopting these tests so that they've not necessarily been tested on people from different backgrounds, people who have multi-morbidities and other conditions. So I think that would be really important. And then there, kind of looking at the near and longer term future, I think there are some really exciting advances in diagnosis. So we're starting to develop digital cognitive tests and test those in the real world. So most people, one of the battery of tests that people receive, whether going through that diagnosis process, is a clock drawing test. So how can you draw a clock, and can you then sort of replicate that in a specific time? The advantage of doing this digitally is that you've got so many more data points. You can see how people are drawing a clock. You can see whether they're pausing at certain points. You can see the orientation on the page. There's so much more that you can measure if you do these tests digitally. So I think there are some there's real potential in looking at that data and taking what might be more subjective data and turning it into objective data through these digital tests. And then we're looking at new models of care as well. So brain health clinics is a real area where you want to get people in when they have really early symptoms of dementia and then start to intervene early. So there are a series of brain health clinics across the UK. Your speaker for the next session in this series will be well placed to talk about that. And so those innovative models of care will be really important in terms of how we diagnose and identify people with dementia. And then longer term, there's much more that can be done. So again, using digital technology, particularly technology that is collected in a kind of unbiased way and a passive way, and trying to use that to move the sensitivity of those early symptoms. So can we move detection 5, 10, or 15 years earlier by using digital tools like speech, typing on a keyboard or typing on your smartphone, things like that. Retinal scans are looking like a promising area to start looking at whether we can detect early changes in the brain through retinal scans. And then increasingly, not only are we looking at the opportunities of blood tests, where you would go into a clinic or you would do a blood test at your GP's practice, but actually spot blood tests. So you can do a finger prick test at home, mail it in to a clinic, and then get your readout there. And that's a really exciting space, because anything we can do to make diagnosis cheaper, earlier, and more accurate, more specific, as well as scalable, is going to be good for the UK population. In terms of treatments, so again, we had very few treatments 30 years ago. We had a few that would manage some of the symptoms of dementia, such as agitation, depression. We had our first drug that was specifically targeting Alzheimer's symptoms going into clinical trials. Many, many more trials later, and many more failed trials later, we'd started to establish some symptomatic management with cholinesterase inhibitors and memantine. There were multiple of the anti-amyloid therapies in late stage trials. And then we were starting to look at treatments that were targeting mechanisms beyond amyloid. So they're beginning to enter clinical trials when we look at 5 years ago. And then now we have our first disease modifying therapies for Alzheimer's disease. We've got over 120 drugs for Alzheimer's disease in clinical trials right now. And actually, most of them are not targeting amyloid, they're targeting other mechanisms, which is really promising. And then we're starting to see, treatments for other forms of dementia in trials as well. I think one of the other things is we're looking at new delivery methods for these drugs. So the current drugs are delivered through IV infusions, which comes with challenges on the NHS. And so we're starting to look at different modalities as well. And this is a picture that you will probably get in any dementia talk. It's updated every year, and it gives you a sense of what the Alzheimer's disease pipeline looks like at the moment. So you don't need to look at all of these details, but it gives you a sense of what the mechanisms of action are, and how many trials are in phase 1, 2, and 3 against those mechanisms. So it shows you how busy the field has been. And what we've seen over the years as we've done this analysis as a field is that we're starting to see more therapies that are targeting disease modification. So not just symptom management, but looking at disease modification. And then we're starting to see a real shift in the field, not away from amyloid, but actually towards other areas of research. So amyloid represented kind of over half of the portfolio 8 to 10 years ago. Now it's 20% of the portfolio, and we're starting to see much more by way of neuroimmune therapies, as well as therapies that target synapses and synaptic health. So this is really promising, because again, dementia is a disease of aging. I suspect that there are multiple mechanisms and pathways at play. And actually, if we're really to make a dent in slowing, stopping, and eventually reversing the effects of dementia, we really need to start looking at multiple mechanisms. So this is the way we think about it at Alzheimer's Research UK, is that you need a suite of treatments that remove the proteins that are building up in the brain. So that's the things like lecanemab and donanemab that have just started to come out. But there are other proteins that also build up, and so we're working on that as a field. you also need neuroprotective neuroprotective treatments, so treatments that make nerve cells more resilient to damage, treatments that protect glial cells that are in the brain that are there to support brain function. And so that's another area of work that is active. And then eventually it's how do you restore the damage that's been done? How do you promote reprogramming of the brain, neuroplasticity? It's not necessarily something that's very close towards the clinic, but it's something that we need to keep an eye on. So again, we've got a number of treatments in phase 3 that are looking at these 3 areas. And by tackling these in combination, we think we will be able to kind of slow, stop, and eventually reverse the effects of dementia. And I'll talk about a few of the things that we're developing at Alzheimer's Research UK. So again, about 10 years ago, we launched our Drug Discovery Alliance. So this is based at Cambridge, Oxford, and University College London. It's 3 institutes that are working on tackling the gap that happens between academic science and industry. So they were set up specifically to move novel targets into the drug discovery space. And they've done really well. So over the years, they're working on around 20 different targets at any one time. They are working to try and broaden the treatment targets that we look at. They've got over 310 collaborations across the globe, but in addition to that, they've got over 30 different partnerships with pharma and biotech going at the moment. So we've been really excited to be working with these 3 drug discovery institutes to form this alliance. And they've done some really exciting work. So one of the spin-out companies that was spun out of the UCL Drug Discovery Alliance is called Astronautics. And raised some Series A funding last year, some 46 million to move its programs into the clinic. So again, these are really key piece of infrastructure and work that we fund at Alzheimer's Research UK to add to the field and to make sure that we're developing treatments that will have an impact for people. We're also a strategic investor and funder of the Drug Discovery Fund. So this was the first dementia fund that is responsible for creating and seeding companies that are specifically looking at treatments that are not based on amyloid or tau. So again, has a really important role in making sure that we're broadening our treatment targets in Alzheimer's disease and other dementias, and have just, they've closed out their first fund and are working on their second fund at the moment. So we're really proud to be investing with them. And then we've launched, this year, we've launched our Clinical Accelerator program. So it's aiming to bring more clinical trials to the UK for people living with dementia. So although we've got an exciting field and over 120 treatments being tested, we have very few that are being tested in the UK. And this is a problem because it means that we don't have as many research active clinicians working as we need in the UK. And it means that centres of excellence don't necessarily have the experience that they gain through clinical trials to adopt new treatments into practice as quickly as possible. So we've launched our Clinical Accelerator program to fund new research active clinicians into the field and grow a network to try and boost trial activity in this space. So it's just launched this year, and we'll be announcing the funding later in the year. And then finally, in this treat space, we are a founding funder and strategic partner of the UK Dementia Research Institute. So this is a virtual institute across 7 different centres across the UK, really focused on accelerating the early stage fundamental science through to translation of dementia research. And they have a number of different platforms that they run, but really a kind of growth engine for fundamental mechanistic research in the UK. And then finally, just to talk a little bit about prevention. So again, 30 years ago, we knew very little about prevention. we had, you know, 5 years ago, we'd made some more progress. We'd published the first report on risk factors, modifiable risk factors, having identified 9 that could help limit the risk of dementia, and a much better understanding of genes and risk genes associated particularly with inherited forms of dementia. But now we've, this summer, additional publication has increased the number of risk factors to 14, and that accounts for up to 45% of the dementia cases worldwide. And then we've launched a Think Brain Health campaign to increase public awareness around dementia risk as well. We've funded some work of a study called Insight 46. That's a 78-year-long study into brain health and dementia risk. So it's a subset of a much larger cohort study, one of the British birth cohorts of people who were all born in the same week in 1946. And what we've been able to do is to use that cohort and those findings really to understand much more around the risk of dementia and how that develops across a lifetime. There's a few key findings that we've developed, understood from this. So things like high blood pressure and how that in midlife can lead to a higher risk of dementia by the time people are 70. They've done some work on the menopause and dementia risk. They've done some work on sport and head impacts and head injuries and dementia as well. So these types of longitudinal studies are really important if we're to understand the risk of dementia that develops over the course of a lifetime. And this is just a graphic that we put together to help people understand when those risks are. So things like early childhood education actually do account for around 5% of the risk of dementia. But that is clearly something that you either have or you don't in early life. And there are a huge number of midlife factors that influence the risk of dementia. When you start to look at them, it's not rocket science. Things like making sure that you're not smoking, you're reducing your alcohol intake, you're looking after your heart health. So a lot of these are related to heart health, are really important. Then as you get older, things like social isolation, air pollution, funnily enough, uncorrected visual impairment are also really important. So I think one of the things that we know is that a lot of these risk factors are interconnected. But one of the things we say is that looking after your heart is helpful. Making sure you're staying connected to people as you age is helpful. And we've launched a brain health check-in tool to help people understand what it is they can do to reduce their risk of developing dementia. So again, if you're interested in that, please do go to our website where you can find a bit more information about that. And then finally, I just wanted to make the point that there are a lot of government-funded programs that are set up to help us in the UK understand how we can reduce risk of diseases in later life and how we can make improvements in prevention. So the UK Biobank has been fundamental in improving our understanding of risk factors, particularly as that cohort of individuals starts to age and develop dementia. But Our Future Health, which has just recruited its millionth participant in the last couple of weeks, is also really important in terms of looking at a broader range of population and trying to get more diverse people into these cohort studies. I think as that program develops, it will be really important in order to understand dementia risk. And then, hopefully I've convinced you that it's a really important time to, exciting time and important time to start to invest in developing dementia research. So again, we've got our first treatments. That's a foothold on the mountain that we need to climb in order to develop new treatments and to slow, stop and reverse dementia progression. But it is something to base things on, and we're starting to see more people come forward for diagnosis, 17% up year on year as a result of the news about these treatments potentially being available. And I think people are starting to see that there's much more that we can do to accelerate research and to build on the progress that we've already made. And just in terms of the future, and so this is just a snapshot of some of the discoveries that have been made in the last 30 years or so, just over 30 years. And actually, there's a lot more that we need to do. So again, we want to see multiple treatment options targeting different aspects of dementia. We want to start to see treatments being given in combination and in a much more personalized way, and moving diagnosis forward to make sure we're tracking symptoms earlier and we're predicting who's likely to progress quickly is going to be really important as we move forward as well. So I just wanted to stop there. I'm going to stop sharing so I can actually see Paul, and really sort of over to you for any questions.
Thank you very much for that great talk, Susan. We have plenty of questions here. I might start with one of mine, if I may. It was great to see the comparison of like the 30 years, right? It was a really hopeful presentation, which is always good because often there's a bit of doom and gloom around neuroscience research. But I have a question about kind of a general scientific question of what do you think would be one of those biggest questions that if Alzheimer's Research UK could get answered, would be in terms of what do you think are the more transformative remaining questions in Alzheimer's that you'd love to have answered?
You've read my mind. I don't know if you've been in the background to my meetings, because we are actually asking ourselves that question at the moment, and we'll be doing some work on this in the coming weeks and months. For me, I think there's a couple of things. I think the first is how do you predict who's going to progress quickly and who won't progress quickly? And I think that's really important, because if you can get people into trials that will progress more quickly, you can actually get an outcome much more quickly as well. So I think that's really important. And I think the other question that we couldn't answer until now is what is happening in the brains of people when we are removing amyloid. So once you tackle that bit of Alzheimer's, what are the other things still at play and how do you tackle those? And I think now that we have treatments that are being used in the US, we hope that they will be used in the UK eventually. What else is still going on? What are the other mechanisms? And I think that's going to be a really important question to answer.
Thank you. Because you mentioned how in the UK there's comparatively fewer clinical studies than other countries. What do you think is the reason behind that?
I don't actually know. That's a really good question. So we've done a little bit of work on this, and I think industry studies have, there's always a lot more clinical trials happening in the US. A lot of the industry studies have moved to Europe in recent years. But I also think there's just a lot more that we can do as funders to try and seed funding. And I think we don't have as many research active clinicians, trial active clinicians as I'd like to see in the UK. Dementia trials particularly are long because you have to measure the effect that your drug is having, and that takes relatively long time. I mean, neuroscience trials tend to be, or neurology trials tend to be long anyway, but dementia ones particularly, and that adds challenge. But I think there's no easy answer to how we get more trials in the UK, but it's a real priority for us.
Makes sense. We have someone from the audience asking something relating to financial support that you touched on here. Does Alzheimer's Society receive government funding then?
Yeah, so we're Alzheimer's Research UK, and we don't receive very much government funding. We would only receive that funding if it was for a joint project joint research project that we were working on. So for example, the blood biomarker challenge that I talked about earlier, one of the government funders in IHR have put some money into that. So we receive that, but we're not sort of government funded. We're funded by donations from the public primarily.
And how do you balance funding those really early stage, academically very interesting, but potentially very far from application projects to the very late stage, sort of just before clinical trials. So how, as a funding agency, what's the best way to balance those two very different approaches?
Yeah, so I think we see the importance of the early stage work as long as there is a pathway to impact, and that pathway can be much further down the line, but as long as the researchers coming to us for funding know that there's a pathway to impact and there's a next step to their research and they've thought that through, I think that's really important, because if you don't provide that engine for new targets and new discoveries, that will in the short term, you might not notice, but in the long term, the innovation will dry up. I think, but in terms of the later stage work, that does tend to be really expensive to do. So our approach there is to work in partnership with others as much as we possibly can. So again, for our blood biomarker challenge, there is around £8 million worth of research in that across the two studies, but we're working in coalition with Alzheimer's Society. So it's Alzheimer's Research UK, Alzheimer's Society, National Institute of Health Research, and Gates Ventures, with funding from the People's Postcode Lottery. So that's where you'll see us working in partnership. And then I think there are some smart things that we can do at that later stage as well to try and invest in making research easier and cheaper. So part of our clinical research program is to invest in sub-studies that give us much more information about disease mechanisms. So if you're running a clinical trial and you've cut the sub-study out because it adds to the cost, we will consider funding that, because again, those studies might give us information that change trial design and make trials cheaper and faster to run in future.
Thank you. So going back to questions from the audience, someone's asking, what sort of costs were the drugs approved today that are not available in the NHS that there were news this morning? What do you think they cost an individual as a ballpark figure? Yeah.
So I am trying to remember reading my briefing on this. We don't know what the cost to the NHS would be in terms of what the companies might be discussing with NHS England, but in the US they're in the tens of thousands of pounds just for the drug. But the challenge is that the cost of diagnosing people, the cost of doing monthly MRI scans to check for the side effects of these treatments, the cost of infusion units is what's adding. So this, more than doubling that cost. And at the moment, NICE doesn't consider cost to society in their calculations. So they're just looking at NHS and health costs. But actually, they're a huge, as you've heard, there's £42 billion a year is what dementia is costing society at the moment. But that's mostly borne out by patients and their families, and that's not included in the figures.
Yep. So we have another question from the audience. We have a lot of them. It's great. If you have any more, make sure you submit them in the Q&A button at the bottom of your screens. So the other question we have is, what would you hope to be the situation with more affordable drugs? So it's relating to this measure in the next 5 years.
So there's already so I mentioned for the two treatments that are now licensed are infusions. So one of them's you go into an infusion unit every 2 weeks, and the other one is monthly. There is already a late stage clinical trial looking at a subcutaneous injection. So potentially people could inject at home, which would reduce the cost. It would reduce the cost of administering that drug significantly and make it much more convenient to administer. I also think if we can develop treatments that have fewer side effects and fewer serious side effects, the monitoring for treatments will hopefully not be as burdensome or costly to the NHS. So again, those monthly MRI scans cost a lot of money. And then I think the other big cost for these drugs is the cost of diagnosis. So at the moment, if you want we need to know, is amyloid in the brain of people that we're treating with these anti-amyloid drugs? Well, the way to do that is either to get a lumbar puncture, which a lot of people don't like getting, doctors don't like administering because that can come with its own side effects, or a PET scan. If we can get blood tests as part of the diagnostic pathway, that opens up the opportunity to diagnose people in that kind of accurate and specific way without the additional cost to the NHS in the same way.
Yeah. Because could you share any sort of more recent promising results in terms of diagnostics? Because this is something that we've touched upon throughout, right? You want to diagnose early, much earlier than symptoms. Are there any recent advances that we'd be excited for?
Yeah, so I think the blood test work is really exciting, and I think a lot of people say, "Oh, this will just be a blood test, and if I get it, it will tell me if I have dementia or not." And that's not what we're looking at. We're sort of looking at this in combination with pen and paper cognitive tests or digital cognitive tests. So it's part of the diagnostic story, but actually, by some of the work that's been done in Europe has shown that by starting to look at these blood tests, you can reduce the need for PET scanning or lumbar punctures by about 80%. So they're really good at, they're not quite as accurate in terms of the people who are in the middle, but on the margins, if your sort of numbers are on the margins, are really good at predicting whether you have Alzheimer's disease or not. So I think that's really exciting. I think there's more to do in terms of AI and digital tests. So again, some of the work that we've supported has looked at whether you can use digital tests and toolkits to predict somebody's risk of developing dementia. And again, there's a paper out in June that showed that prediction for dementia risk was more accurate using some of these digital tests and AI modeling than it was if a person saw a clinician. So I think moving into that space is really important. But when we do that, we need to be really mindful that you've got to test on a representative population, because you could be building bias into the equation if you don't. So I think that's going to be really important as well.
Yeah, because you mentioned how dementia is the umbrella term for a lot of different sort of diseases. Even within Alzheimer's, do you think, because it's quite a heterogeneous disease, right?
It is.
Do you think also diagnosis of sort of subtypes and even more granularity to that diagnosis of dementia could help move things forward?
Yeah, I think it is one disease, but it probably does have subtypes, and actually we do need to start looking at that. So there are papers out that are looking at some of the genetics related to it, but I think we need to get better and more accurate and earlier with diagnosis before we start to really unpick that. So if only 2/3 of the people in England are being diagnosed at all, or if that's the target, and they're being diagnosed very late and they're not necessarily being followed up properly, I think that's a real challenge. And then there was another part to your question, wasn't it, which I've forgotten. So sorry if I've not answered all that. You can ask it again if you want.
No, I think that was it. I think it was about kind of unpicking within the subtypes of Alzheimer's and seeing whether that could benefit.
The other thing I was going to say, there are mixed dementias. So people with Alzheimer's can get vascular dementia or Lewy body dementia. So I think unpicking that is very complex as well.
Yeah, no, it makes sense. No, it makes a lot of sense that you say about first increasing that number from 6 to 6 to higher, and then unpicking it further.
And making it earlier, right? So it's not helpful to do it at a very late stage. You want to do that earlier.
No, definitely. You discussed and you touched upon the stigma that people have, and that stopping them from maybe getting diagnosed early on. What do you think the main misunderstandings or misconceptions about what can or can't be treated in dementia on Alzheimer's?
Yeah. So I hear a lot of people say, well, there's not really anything you can do about it. It just happens as we get older. And I think there's a little bit of ageism in that. There's a little bit of, this is just inevitable. And I think that's partly because it was, until quite recently, a disease that wasn't seen as treatable. And the new treatments will change that. So I came up in the field of multiple sclerosis. So I worked at the MS Society for many years and saw those attitudes shift as we saw the treatment landscape shift. So when I started there, we had 5 treatments. By the time I left, we had on average 1 a year when I was working there. So we have over, nearly 20 now. And the attitudes of clinicians and the attitudes of patients shifted massively in that period, and they became much more proactive and activated in what they wanted to see and what their expectations were of how they were treated by their clinician. And I think that pressure on clinicians was actually quite helpful in shifting how people were treated as well. So I think we're at the very early stages of that in dementia. People haven't had those treatment options, but now that they're starting to come through, I think that will shift those public attitudes as well.
That's great. I think we're running out of time, so I think we'll stop with that hopeful message of more treatments will come. The stigma will hopefully be eradicated in the future, and we'll get early diagnosis. I want to thank you again, Susan, for an outstanding talk. And I'd like to finish up with some sharing some slides about the next event. So if I may, there you go. The third event in this series is on Wednesday, 20th of November, and it's entitled The Brain Health Movement in the UK as a Life Sciences Priority. So I encourage you to go to our website, we can see here on the right-hand side of the slide, and sign up to that. Remind you that SCI membership comes with plenty of benefits that you can see highlighted in the slide. So if you'd like to join us, go to www.soci.org/membership. And with that, I'd like to thank you all for your attention and for joining us today. And thank you, Susan, for an outstanding talk.
Thank you.
Have a good rest of your day. Bye-bye.